So this next talk will be the role of ultrasound in diagnosing pelvic venous disease. So I always like to know, kind of the audience, who does pelvic reflux or pelvic venous disease to evaluate for varicosities? Yeah, kind of, sort of. Okay, well, hopefully after this I'll give you some tips and tricks on how to evaluate these patients and what we're looking for. So we're going to know the facts of what pelvic venous disease is, what causes it, how we can identify it on ultrasound, and then the treatment options available for these patients. So pelvic pain, I know we were talking about this earlier this morning, so I've got it now officially in a slide. Approximately 1 in 3 women will experience chronic pelvic pain at some point during their lifetime. And by definition, we're thinking chronic pain to be lasting longer than 6 months and not related to a woman's menstrual cycle. So that's kind of the background, I guess. And when we're seeing these patients come into the clinic, a lot of times, majority of them will be women, and they're going to be coming in and they're going to be describing different type of pain symptoms to you. So as a sonographer, we can kind of gather that type of information by getting a detailed history from the patient. That some reasons or causes for chronic pain, particularly in women, is endometriosis. You can have musculoskeletal problems. There's other things that are going on, fibroids, irritable bowel syndrome, or painful bladder syndrome. But the one thing that we'd really be wanting to hone in on is whether or not they have pelvic venous disease, formerly known pelvic congestion, which we briefly talked about in the previous talk, so I'm not really going to go over that in a lot more detail, but I will be referring it to pelvic venous disease rather than pelvic congestion. So what is it? So what's happening inside these veins that are causing this chronic pain in women or in patients in general? So kind of knowing the background as far as is these veins that start to form around the uterus and ovaries that are causing a lot of pain. So that can either be causing or coming from a compression. So that would either be the left renal vein that then refluxes down the left ovarian vein, or from a common iliac vein compression that then refluxes into the internal. The third way is just reflux within the ovarian vein itself. So when we're doing these scans, we're going to be evaluating and scanning all 3 of those areas. So on women, some of the symptoms that they're going to be describing is a dull, achy pain in the pelvis or lower back. And that's going to be worse when they're standing or sitting for a long period of time. Incontinence is another one, right? So with the pressure of these enlarged veins around the uterus and ovaries, it's also pushing on the bladder. So they're going to have this urinary frequency, or at least a feeling of it. Postcoital pain, which is just discomfort after sexual intercourse, for the same reason, where these veins are kind of engorged and there's just a lot of pressure and achiness and heaviness that starts to form around the lower pelvis. They're also and can be presenting with vaginal or varicose veins, so that we can see those patients, and when we're doing our physical examination, pick up on those. They can also have varicose veins on the top of their inner thighs and the back of their thighs. Men, they're going to be presenting with varicoceles, which can result in testicular fullness, pain, or even possibly infertility, flank pain, and then hemorrhoids. So when we're thinking or we're looking at these patients, if they're coming to us and you do see these veins, maybe on the top of their thigh or vulva area, we have to be kind of thinking beyond just the legs and knowing there's specific leak points that we have on the pelvis floor that these veins from the uterus and ovaries are kind of trickling through. And that's what we're seeing, is kind of this trickle through effect. So you have different leak points within the pelvis. You have an inguinal, which is the I, obturator for O, perineum, and gluteal. So in my experience, I see a lot that come from the perineum, and it's easy to identify. As we can see here on these pictures, it's showing different presentations of where these veins are coming from. So it's not going to be your typical medial calf varicosities. These are going to be out of the ordinary varicosities, and you're going to need to stand your patients. Look at your patients, have them loosely dressed, either shorts or a gown, so you can go up high. So you need to be able to see where these veins are coming from so that you might not even be doing a pelvic reflex study, but you can tell your provider, hey, there's something more proximal going on here because I can see these trickle varicose veins within the legs. That is a pelvic source varicosity. It's hugely important to identify these veins. And when you're looking at them, any veins are kind of coming from the top part of the anterior thigh. You can kind of do an I/O leak point. Again, as you're kind of seeing that, the far right images, those would be more towards the perineum. So again, these are very common presentations of pelvic source varicosities that we're going to see. And within the last couple years, there's been a huge push in trying to quantify pelvic venous disease, similar to how we do a SEEP score. So we're all very familiar with the SEEP scoring classification, but now we're trying to transition that into defining the pelvic venous disease, the level of it, the complexity, where is it coming from? And again, that came from that multidisciplinary international study where they're trying to then kind of make a standardization for these patients so that we can get them into maybe trials or having an adequate treatment plan for these patients. So they're breaking it down into symptoms, varices, and anatomic physiological domain. So you can see at the top there, there's SVP-AHE. And then the A stands for abdominal or pelvic, H is for the hemodynamic abnormalities, and E is for the underlying etiology. So it's really kind of honing down on where these patients presenting with their symptoms, where their varicosities are shown on their legs, or is it only belly? So I think this will be advancing the field dramatically. And here's just the overview of the symptoms, varices, and pathophysiology. Here's the chart, which is, I'll leave it up to you to read because it is kind of wordy. It's helpful, though, for the patients. So when we're looking at, and we're kind of transitioning into now the ultrasound diagnosing these obstructions and causing these varicose veins to get engorged, one of the areas that we're first going to start looking at is the left renal vein. So the left renal vein gives rise to the left gonadal vein, as you can see there towards the bottom part of that picture. So what we're kind of looking for is what kind of narrowing, if any, is present of the proximal left renal vein. So if you have formerly known nutcracker or left renal vein compression, if you have a stenosis there, the blood can't leave the kidney, right? So what it wants to do then, because blood is lazy, it wants to go the path of least resistance. So then it's going to drain down to that left gonadal vein, and those veins around uterus and ovaries are going to start to form. So you can see that down arrow, kind of the same thing. So patients are going to be presenting with specific symptoms. Flank pain, hematuria, pelvic pain, or varicoceles are all very common symptoms of left renal vein compression. And we're looking again for a velocity ratio of 5. So we're again kind of moving away from just visually does this look compressed to let's put in a number on this, right? Ultrasound is unique because we have hemodynamics. We can use velocities and we should use it to our advantage. So if we're gonna say a vein is compressed, the left renal vein compressed, and the velocity ratio needs to be 5. So we're gonna be dividing that at the narrowing or towards the IVC is typically where you're gonna see the compression to the kidney side. So the compression isn't always going to be from the SMA. So that's why we kind of veered away from calling it nutcracker, because it can also be caused from the right renal artery. The end result is the same though, right? You have a stenosis proximal or IVC side, and then you're going to be dividing it by the kidney side. So we're looking for 5. The interventions for left renal vein compression, you can stent it or interpositional bypass graft. Sometimes the best thing is just to leave it alone, and the collaterals will form around the narrowing itself. So this again is one of those stenoses that will change with position. So similar to how we're talking about the left common iliac vein being compressed, you need to do the same thing for the left renal vein. I would say probably 9 times out of 10, this vein pops right open when you have the patient in a lateral decubital position. So try it. It's easy. These patients tend to be very thin because there's not a lot of fat between the vein and the artery that it's getting pushed up against. So when you're having them on their back, you have the artery pushing against it along with the gravity causing a stenosis. Turn them on their side, get all of that pressure off of there, and you're going to see a dramatic change in the velocity and then the diameter as well. So you can see here, prior, that was the velocity, that's a diameter change from lateral decube. And then this is a same patient. You have a 2.3 diameter in B mode supine position, lateral decube, what is that? 8.3, right? That's huge. So check that, because if it's reflexing into the gonadal vein, tilting that patient or putting them on that side, it can go from retrograde to then maybe a to-fro flow, or possibly, if it's severely compressed, into antegrade flow. So this is one of the things that you'd want to double check to see if is it positional compression or is it fixed compression. And the times when it is a fixed compression, I'm noticing it to be more from the right renal artery rather than the SMA. So just kind of something to keep in the back of your mind. The second more common area to have reflux is through the internal iliac vein, and that's going to be caused from a common iliac vein compression. We went through a lot of that during my previous talk, so I'm not going to go into a lot of depth with it, but mainly to know that the flow, if it's severely compressed, is going to get to the point where it can't leave the vein, the common iliac vein anymore, and it's going to start retrograde feeding into the internal iliac. So here's a patient that we had seen. Her diameters of the proximal common iliac vein are very, very small. Compared to distally, her velocities were high. This was prior to the point where we weren't tilting the patient or turning them onto their side, so I can't give you that information. But it was severe enough that it was causing retrograde flow into the internal iliac vein. So this is an example where the varicosities around those uterus and ovaries would be caused from the retrograde flow from the internal iliac vein. So again, common symptoms that we're going to be seeing for iliac vein compression would be the unilateral leg heaviness, achiness, fatigue, possibly ulcers, skin discoloration, venous claudication. We all know that type of things. But then we're going to also add into the point that it could be causing pelvic veins from engorged periuterine varicosities from that retrograde internal iliac vein. So typical intervention for common iliac or iliac vein compression would be stenting. We did hear some great talks about that earlier, so we're not going to go into that in a lot of depth, but just to know that that's the way that we would treat these patients. And it does reduce the amount of periuterine or even cross collaterals from along the pelvis. So it is obviously one of the ways to kind of treat those symptoms. And then the most common source for periuterine varicosities would be reflux within the left gonadal vein. So now these are typically going to be female, and they're going to be women that have had multiple pregnancies. They're going to be younger, so pre-menopausal, and they're going to be lower in BMI. So they're going to be small women that have had large babies, are tending to be the patient type that we're seeing. So when you're trying to scan and identify that gonadal vein, I know this is one of the things in talking to folks throughout the years is it's so hard to see that gonadal vein. And I get it. It is hard. We're dealing with bowel gas and everything else, and it's like one extra thing that you have to look for. The biggest trick that I can say that would help you along the way is finding your psoas muscle. These women, again, are going to be small, and that muscle is going to pop out. You're going to see it about the level of your belly button, and you'll be able to see that on both sides. The gonadal vein is the only vein that's on top of the psoas muscle. So you can follow that all the way up to the renal vein. If you want to follow the left side, the right side will dive into the IVC at around 10 o'clock if you're looking at a hand clock. Abnormal flow, of course, is retrograde, so it's going in the wrong direction. It should be antegrade and feeding into the renal vein. And it's important to identify branches on the gonadal vein. I can't stress that enough, because there are times when I'm seeing these patients, and I have over the years, where I've mistaken what I thought was a gonadal vein, but it was truly a duplicated IVC. And the thing is, that vein is gonna join an iliac vein, and it's not gonna join a reproductive organ. So follow it to the point where you can see branches. This patient in particular, she was very confusing because she not only had a duplicated IVC that I called a gonadal, but it was also retrograde filling. So it like checked every single box, but it was a duplicated IVC. So take the extra 2 minutes and identify branches from that gonadal vein. That'll tell you the difference between a duplicated or truly gonadal. When looking at perauterine varicosities, veins are normally seen on the uterus and ovaries. That does not mean they're varicose. We're looking for veins that are over 6 millimeters or greater and multiple, not just one, not just two, but a lot. Like you're thinking varicose veins, but around the uterus and ovaries. So have the patient, if possible, come in with a full bladder because it provides a really, really nice window of the uterus and it kind of tilts it back. So you're able to see those veins without so much bowel obstruction. And then this article here, so pelvic vein reflux is the second most common cause of pelvic pain following endometriosis. So this is a huge issue for women that maybe is underdiagnosed. And 40% of women had pelvic varicosities per CT imaging. So that is one of those things that doesn't necessarily mean that they're going to be treated, but they have pelvic varicosities. And in at least our facility, we have either a top-down or a bottom-up approach, depending on where the patient's having symptoms. Like if they don't have pelvic symptoms, they're not going to go after these veins. If they only have lower extremity veins that we saw previously, it's just going to be from a bottom-up with foam echo sclerotherapy. So to treat a left gonad or any gonadal vein for that matter, they're going to be using coils to then thrombose the ovarian vein along with sclerosins into the varicosities around the uterus and ovaries. And then if it's the lower extremity, again, they're just going to do foam. They're not going to necessarily go after all of the pelvic stuff if the patient doesn't have symptoms, right? Because the main thing is getting to the patient so they're asymptomatic or at least improve symptoms. So again, when you're scanning these patients, it's still important to identify that you have pelvic source varicosities, but it's up to the doctor whether or not they want a pelvic study done. So kind of in recap here, the things that we'd be looking for to rule out or identify if there is compression within the iliac veins, along with the left renal, we're looking for a velocity ratio of 2.5 in the common iliacs to be considered a significant stenosis, and 5 in the renal vein. So check those veins supine and lateral DQ. Confirm that the compression is still there. You want to still identify both of the gonadal veins. So a lot of times if that left side is large, so that gonadal vein, if it's abnormal, it's going to be big. 6 millimeters or greater, that's the size that we're kind of looking for. And then if that's the case, the right side is just as important because it can be acting as a collateral. So you still want to measure the contralateral or the right side because even if it's not refluxing, it could be acting as a collateral to get the blood out of the pelvis. So it's important to know which direction both gonadal veins are and the diameter. Look for the psoas muscle. That is huge when it comes to identifying the the gonadal veins. The psoas muscle is obviously a very fixed structure, so you can see it, and it has a muscle striation. It's key to being able to identify the gonadal veins, and then having these patients in reverse Trendelenburg. So you want as much blood engorged into these veins as possible. So you can have the patient supine, but tilting them kind of adds the pressure, particularly on the valves in the gonadal vein, so it can go from antegrade on supine to retrograde in a reverse Trendelenburg. Standing is another option. It's just a little harder to do for the same reason that everything shifts down. Bowel gas kind of shifts in that way as well. So reverse Trendelenburg has been key to identifying that. Look for those branches, that's going to be huge. And then again, uterus having the full bladder, and then looking for multiple varicose veins. Veins on ovaries is normal, veins on uterus is normal. We're looking for anything large, so 6 millimeters or greater. That's it. If you have any questions or would like to email me, feel free. Thank you.
I'm back. So this talk, I'm going to be talking a little bit about the increasing technical ultrasound requirements for advanced AAA therapy. Dr. Lassar loves to give me long titles and then let me figure out how to get after them. So we're going to talk a little bit about AAA, abdominal aortic aneurysm, and what some of the intervention to prevent that is, and then what that means for ultrasound as far as what we need to look at. I didn't pick up any disclosures since this morning. I tried to visit some vendors, but I'm still working on it, so nothing yet. Okay, AAA. So over 30,000 deaths every year as of 220 were responsible from or caused by ruptured AAA. This is the 13th leading cause of death overall in the United States. And so if we look at that little graph, 1.1 million people between 50 and 84 are estimated to have a AAA. But only 50,000, that small green circle, are ones who are getting a procedure to try and prevent a rupture. So when do we start to think about intervention? When do we worry about rupture? Well, the incidence of rupture increases significantly once an aneurysm goes over 5.5 centimeters. So we're definitely watching for that. We follow these people, right? When somebody has a AAA, we were watching. And if their aneurysm increases in size more than 5 millimeters in 6 months, that puts them at a higher risk for rupture. So why is rupture so worrisome? Dr. Lassar shared this slide with me. Of 100% of patients that have a ruptured aneurysm, 75% of them will die before they reach the hospital. Now, of that 25% that actually make it to the hospital, half of them will die before they reach the OR. So we're left with 12.5%, and out of that, only 60% of them can just automatically have an EVAR when they make it to the OR. So out of our original 100%, 7.5% can undergo an EVAR. That was just shocking to me. I mean, I knew it was serious, but I didn't know how large the percentage was. So it's really important for us to try and prevent a rupture, right? Most people are not going to make it through that. So there used to be open repair. There still is open repair, but we're going to talk about endografts. And endografts are preferable to open repair for a number of reasons. The fenestrated endovascular repair is minimally invasive. So what that means is they're putting an endograft, they're going in through the groin, bringing a graft up into the aorta, and then expanding it to go inside of the normal part of the aorta to take pressure off of that expanded aneurysm area. They have a shorter hospital stay with this. It's far less invasive. Smaller incisions and less scarring, so any of your patients who are trying out for modeling, they'll appreciate these. They have a rapid return to normal physical activity. Compared to being cut open and pulled open and all this stuff, they have much faster recovery time. And there's fewer complications than there is with the traditional open surgery. So what am I talking about when I say EVAR or FEVAR? EVAR, or endovascular aneurysm repair, it's like I said, it's that little tube that goes in through the groin, and we think about it kind of like a straw inside of the aorta. So EVAR is a simple tube. FEVAR is a type of EVAR. It's the same tube, only they've now added some holes and some scallops because the aorta has branches, right? And so with traditional EVAR, you're going below the renal arteries, and you're kind of avoiding that upper area where you have SMA and celiac and the renal arteries. But we have a lot of patients who have aneurysms in those areas. So FEVAR just means that there are some new innovations to try and cover the area that has these branches. So here's a traditional EVAR. We have the aortic aneurysm here, pretty big, and then this is the EVAR inside of it, kind of reducing that pressure. And this is a picture of what it would look like. We see it below the renal arteries, just a straight tube with a leg on each side, to help take care of the aorta. And there were ways to add branches to the EVAR. I was amazed by this picture when I found it because this octopus one was amazing. I mean, there's stuff going in and out all over the place, and the periscope, they've got stuff tucked in and out, and so there are ways to do it. But when you look at these pictures, look at all these connections and overlaps and things that have to kind of fit and push inside of each other. So when we have all those connections and different things, we can have an increased risk for leakage. So this is a more modern approach. We still have the straight tube there, but now there's a hole built in on each side for renal arteries. We've got this hole here for the SMA, and then there's a cutout here for celiac trunk. And this is just one type. There are all sorts of types that we're going to look at, but just to show kind of a real picture of what one of these looks like with the new technology. So here's some different types that can occur depending on where the aneurysm is. They can go infraceliac, low supraceliac, or high supraceliac. So we can see this one is below SMA. This one goes above the SMA with a cutout for the celiac. This is above all of them. We've got an aneurysm here, and the endograft can go above where we used to be able to go. And so it's nice because it gives the surgeons options. We are not restricted nearly as much as we used to be with some of the different anatomy that people have. So this is kind of a step-by-step of how one of these might be done. We have the main body of the graft that goes in A, and then we see renal arteries get taken care of through these in B. C, they start with celiac, and then they do SMA and deploy those stents. And then in D, we have the first leg, and E, we have the second leg. So look at all of the different branches that are taken care of by these new ones. I was just blown away by some of the different choices that are out there now. There are some challenges to this technique. It's not perfect. One of them is target vessel stenosis. So if the vessel, say SMA, has a greater than 50% stenosis, that can mean that the patient is on the table longer, which just can increase the operative morbidity. There's angulation. So if the aorta is tortuous, bent, or twisted, it can make it more difficult to get all of these holes and stents lined up just right. And as it talks about, the misalignment of these fenestrations or these holes can create target vessel occlusion. So it's really important to try and get everything lined up the best we can. And when we're looking before a patient has intervention, that's something that we might note. The aorta is tortuous, or even the origin of the renal arteries, things like that, because it can make a difference on what they can put in. We also have to worry about the diameter of the aorta, because they can't place the top of the device in a section of the aorta that is preaneurysmal. If that section were to become aneurysmal, there's no way to repair the device. They have to remove it currently. So it's important to note where the aneurysm starts and to pay close attention to areas that may be dilated but not quite aneurysmal yet. So how does ultrasound play a role? Why do we care about this? Well, post-endovascular aneurysm repair, surveillance is lifelong. So we will always scan these patients as long as they're around. After they've had it placed, we usually do an ultrasound at 30 days, 6 months, a year, and then annually after that. So we can really get to know some of these surgical patients and pay attention to how things are progressing through time. When we're looking with ultrasound, we look in long and transverse with duplex. We're looking to try and see where does that graft start and where does it end. Now that there are so many options, it's important to note where that proximal attachment, where the distal attachment is, and kind of the scope of the graft, what it covers in the aorta. It's also important to note the aneurysmal sac size, because once that graft gets placed, the sac should get smaller. It shouldn't be leaking blood. We would be taking the pressure off of it, and it should reduce in size. And then we look with color Doppler to see if we can see any kind of leak. So leaks we're going to talk about in just a little bit. Leaks can happen with these grafts, and so we want to see some of the hot spots that they can occur and try to prevent those, or try to look for those to see if they're happening. And then we need to pay special attention to the proximal and the distal attachment because those are important. And then we got to look at the origin of inferior mesenteric and lumbar arteries because we're going to talk about those can be the cause of a certain type of leak. So this is good technology, right? It's an important improvement that's been made, but there are some things that can happen. These can expose patients to risks that they wouldn't have with an open repair, such as aneurysm sac enlargement, endoleaks, stent fracture, and graft migration. And we're going to talk a little bit about the endoleaks especially. So here's our different types of leak. Type 1 happens at the proximal or the distal attachment sites. Type 2 is flow that actually comes into the sac from maybe one of those lumbar arteries or inferior mesenteric. Type 3 would be caused if there's a hole, a tear, or a separation in one of those connections or in the graft material itself. Type 4 is when blood just kind of oozes out of the material because of the material being slightly porous. And then type 5 is just an increase in the aneurysm sac without being able to detect an actual leak. All right, type 1. Type 1 occurs in up to 10% of cases, and it's always considered significant. Some of these can resolve by themselves, but type 1 is unlikely to resolve itself. So it's very important for us to try and find these because these are ones that the surgeons will definitely want to know about so that we can try and help that patient. Here's a picture of the proximal stent attachment, and we can see all this flow outside of it. So here is the aorta, and then the graft inside of it, and then we see all this flow leaking out at that stent attachment. And then the waveform in one of these is very to-fro and turbulent, and it's definitely not going to be triphasic, monophasic like our normal waveforms. Type 2 is the most common. Type 2 is when another artery comes into the sac from the outside. So the graft isn't actually leaking here, but there is something that's coming in that's putting a little bit pressure on the aneurysm, and so it's something that we watch. It's not always going to be surgically repaired. Sometimes they'll resolve spontaneously, but there are cases where if it's causing a problem, they'll go in and embolize one of those arteries if it's causing too much damage. Type 2 leaks are seen in up to 25% of cases. So between type 1 and type 2, that's 35% there. And when we look at these endografts, when we're doing the aortas, it's important to take our time to set the sensitivity of the machine as low as it will go, because some of these are small amounts of leak, small flow, and we will see subtle changes over time. But if we look, number one, if we optimize our image, and then something else that we do at the Vascular Institute is when we look at these, we look at them supine but then we also decube them to each side to look at the graft from different angles. And we've actually seen sometimes endo leaks that we weren't able to see supine that we found by rolling the patient up on their side. All right, there's a few more subcategories that we don't really get into, but they are there. Type 3, like we talked about, is an actual mechanical failure of the graft. So there's some sort of tear, some sort of hole, or some sort of separation that happens where the blood flow will leak out. Type 4 is where it just oozes out of the material. These will typically resolve themselves, so we don't have, I've not seen one myself, but it's not one that is as common. And then type 5 is called endotension. It's not an actual leak, but the aneurysmal sac will continue to grow, and we just can't see why with ultrasound. So to sum up, untreated AAA can be life-threatening. We really want to pay attention to these for our patients so that we can do the best we can to prevent that. Endovascular repair is more commonly replacing open surgery, and it's getting more and more advanced as we go with all these different options and all these different fenestrations. So it's important for us to look at the branch arteries when we do these. You know, we're used to seeing the endograft kind of below the renal arteries and in the iliacs, but now with these other options that are out there, we have to pay attention to the renal arteries and maybe SMA as they get more and more advanced. And so that's just something that we need to add to our repertoire when we're doing these. And ultrasound is this valuable tool. We can look at it in real time, and we can see the blood coming in from the IMA maybe, or maybe we can see a subtle leak that's happening at the distal attachment site. So it's really important to optimize our machines and to take our time looking for these different types of leaks, and then to know the different types of leaks so that we know what we're looking for and we can report it accurately. So those are just my references, and then I told myself I would have this is my last talk, so I get to breathe easy, and I wanted something that would make me smile. So that's my family.
All right, good afternoon again. Chad, that was an excellent talk, and Sarah, loved yours as well. I mean, we're trying to highlight some of the different technical changes and the different advances, and carotid surgery is also one of those areas where there's been some change in how we think about it, how we do it, and how do we prevent stroke from happening. And then to see, is there really an impact on the ultrasound lab for you folks. So let's define the problem. The stroke remains the fifth leading cause of death in the United States. That's a fall from the third leading death. So there's been an improvement in that area. It's the leading cause of serious long-term disability. About 750,000 strokes occur each year, and the cost is greater than $20 billion. But when somebody has a stroke, one of three things happens. You either get maimed from the stroke, you can't walk, can't talk, can't see. You die from the stroke, about a third die from the stroke, and about a third have the stroke but recover. And so we know that the carotid artery is one of the areas that can cause the stroke. It can be cardioembolic from AFib, but carotid artery stenosis is definitely in that should be in your thinking when this happens. And we know that as we age, atherosclerosis of the carotid artery affects about 75% of men and about 62% of women over age 65. And so it becomes more and more common as we do get older. So as you can see here in the United States, there's about 800,000 CVAs a year, 600,000 are new CVAs. The incidence, fortunately, is declining, but that means that there's about a CVA about every 40 seconds or so. Carotid endarterectomy is the optimal treatment management strategy for high-grade non-disabling stroke patients with symptomatic disease, and then high-grade asymptomatic carotid stenosis. And if you look at the map, I mean, just look at where Tennessee is. It's right in the middle of that zone where the stroke belt is. And so, you know, it's great that we have one of the country's leading stroke centers right here in our backyard, but it's also unfortunate that we have to have a leading stroke center in our backyard. That's just the reality of the demographics of our region. So what are the symptoms? Unilateral facial extremity weakness, speech difficulties, vision problems. TIA versus stroke is a 24-hour thing. If it's after 24 hours, it's usually considered a stroke, but it's be fast. You want to look for balance for eye, for face, arm, speech, and then time is, let's get them to the ER. So let's say that again. You have a TIA, you have a stroke, a patient, you need to go to the ER. Now, we're all medical professionals. We know this. Patients don't know this. So you got to tell them, especially if you know they have carotid disease. Hey, if you're having a stroke, call us. Having a TIA, call us. If you're having an event, go to the ER. Do something where you get medical help. So then, when we have carotid artery stenosis, when are we supposed to worry about it? That looks kind of severe to me. It looks like a shark bite, really, right out of that artery. But it's right here. And you know, obviously, as it narrows, it becomes more of a problem. Or if there's a friable plaque, that becomes a problem. But at some point, when we listen to a bruit, hear a story of a TIA, we're going to get some form of imaging. It's either going to be an angiogram or a CTA. This is the angiogram showing the stenosis, or most commonly an ultrasound. You know, this is a $3,000 test, and that's probably more than that. And that's, you know, the ultrasound is about a $300 test. And so the techs get very good at doing ultrasounds because it's a very good way to screen patients. So a lot of the clinical trials, the early work was in the 90s. This is where we looked at patients with symptomatic carotid disease and when should we operate. And that was the North American Symptomatic Carotid Trial, NASET. And what they found was if you're over 70% blocked, statistically you're better off having surgery than best medical therapy. That went down to 50%. So even if you're over 50% symptomatic, you should probably have an operation. Under 50%, it was not statistically proven to be a benefit. And so that was under 50%. And so for the asymptomatic patients, if you had an asymptomatic lesion and you found a bruit and tested them, and if they were over 60%, then that was the cutoff for when we should consider an operation for patients with asymptomatic disease who are otherwise medically healthy. So the surgical management is intervention. Surgical intervention is really for all symptomatic patients over 50%. The surgical intervention for high risk, greater than 70% patients for asymptomatic disease, 70% by ultrasound, and use of carotid artery stenting in selected cases for high surgical risk patients. And so carotid stenting has been around for about 20 years. Carotid surgery, the first one was done in 1951 by 3 different surgeons, all claiming to do it the first one. But that's surgeons. I mean, that's just how it works. And so that's been around 80 years. And TCAR, which is something we'll talk about in a moment, it's been only around for a few years. So medical management, everybody needs to have medical management. If you have this problem, you want to deal with risk factor modification, control hypertension, diabetes, smoking, statin use, antiplatelets, and then getting patients to exercise and be active. And that's a fairly standard thing. Now, carotid endarterectomy, there's about 180 to 200,000 cases performed each year. It's the most commonly performed vascular surgery in the United States. Its benefits are pretty well established from the randomized clinical trials, and so it's a very common type of procedure. And it's basically, you know, I describe it to patients as this is plumbing. You have a pipe. We have to clamp both ends, and then we have to open the pipe and remove the plaque. And it's the plaque that breaks apart and travels to the brain that causes the stroke most often. And a lot of times we would put a patch on. This is a patient that had a TIA, monocular blindness of one eye, and then we did an ultrasound, found she had a stenosis, and if you see this little area right here, this is where the plaque, the little plaque ruptured, and the debris from the inside of that plaque fell out to the circulation and then up to the brain, and that's what caused the TIA. This is the lesion on the angiogram, so you see how obstructed it is, and this is actually what we take out during surgery. So the standard endarterectomy, we can do EEG where we put monitors on, or we can do use heparin and different techniques to actually repair these arteries. Closing with a patch is a very common way to do this, and then post-op ultrasound to test for this. The additional term, which is important to know, if you're imaging, a carotid with a patch, it's going to be much more bulbous. You could have edge problems where the patches attach. Eversion technique is very different, where we actually divide the artery, the internal, off of the main carotid, wide, to create a wide type of patch, and then we peel back the plaque. So the plaque is here, and we actually just peel back the artery, and that plaque releases. And then we just basically sew the artery back together again in this fashion here. And so when you do a standard carotid endarterectomy, you can do it with a shunt. So there can be shunt problems where the shunt distally might cause a tear. So a lot of doctors like to do selective shunting, where we would use maybe EEG or transcranial Doppler. Maybe some of you guys in the hospital have used TCD in surgery, stump pressure, cerebral oximetry. But these are just ways to try to avoid a shunt if possible. Now, I tend to do the eversion technique, and I usually do not patch. I do my patients awake under sedation, and that's just the technique I like. And still, about 15% of those patients would require a shunt. I have very few claims to fame in surgery, but I did write a paper showing that if you drive the systolic pressure up to about 200, the shunt rate goes down to 1%. So I tend to do that for most of my patients, and this is the actual type of procedure that I would do. So this is, we use ultrasound to localize the carotid, common carotid, and then its bifurcation. I can then mark on the skin, exactly where the lesion is, get them into a proper position. And so we make a small incision, go down and encircle the common carotid here. The internal is right here, and this is the external with a little blue loop attached to it. And so that's the internal coming right there. So then we're going to divide that internal right here, which is, now you see the artery divided, and you can see the plaque on the inside. And as we start to work, you can see that the plaque is held right here, and the artery is just basically peeled off of that plaque. And so the plaque will come out almost 2-3 inches long as we actually remove it from the body. And then we would repair or clean out any of the common or external, and then actually just sew the two arteries together. So here is the internal, here is the external, the common, the little defect right here where you're sewing it back together, and this is what it looks like afterwards. And that's a fairly common technique called eversion endarterectomy. So this is all important when you're scanning these patients to know exactly what operation the patient had, because this is obviously going to look very different than if it had a large patch on it. This is going to be much more standard. And so that's after we close. So sometimes when you have lesions like this that might be related to radiation, might be related to recurrent carotid disease, they've had surgery before, we have to maybe consider different options. And one of the options is transfemoral stenting, and that's where we come up from the groin. We pass the wires and catheters into the carotid arteries. We can take pictures, figure out where the lesion is, and place a small stent. And they're saying about 18% of the time that's what happens in the United States. Carotid endarterectomy is about 82% of the time. That's where we open the artery and do the surgery we just talked about. So I would say in clinical practice, that's still pretty true for me. I'm about 15% of my patients are carotid stenting. transfemoral stenting, been doing that for 20-some years. So I kind of do both operations depending on when the patient needs it and what their specific problems are. So when do you consider stent versus carotid surgery? Well, if you have a symptomatic stenosis, that's the inclusion. You have to be surgically inaccessible. Maybe it's too high or too low in the neck to operate. Contralateral carotid occlusion or recannulation of a carotid occlusion. So if it's been reopened, someone that's had a stroke and it's been reopened during the time of their stroke while they clean out the clot in the brain. That's a very common scenario. Someone that has medically high risk, grade age greater than 80, CHF, recent MI, severe COPD, or restenosis after carotid or radiation. So those are the reasons why I might consider placing a stent in a patient. And same issues, but in an asymptomatic patient with a high-grade lesion is still a reasonable thing to do. So this is a 64-year-old white female presenting with a left ICA occlusion. So she has an occluded left carotid and a 80 to 95% stenosis of the right internal carotid artery. Past medical history of hypertension, CVA in the past, ×2, depression, social history, significant smoker, 1.5 packs per day for 45 years. And she has a right neck bruit and a high grade 3, 70 to 99% right ICA stenosis by ultrasound. Ratio is 6. And so she met all the criteria. We're going to go in via angiogram, and we're going to go into the right carotid and look at the artery. And so this is actually her lesion. And so we go ahead and place a wire past the lesion. That wire has a little basket on that. I'll show you that in a moment. And then we can place the stent in that area. Then we're going to deploy that stent, and so you can see on the outline kind of the hourglassing of the stent right here. We usually do an angioplasty afterwards where we can open that back up again, and then the completion imaging. This is the little filter that I was talking about that will strain the blood while we're deploying the stent to prevent embolization. And then this is the repair after the stent has been put in. And so then we remove that little basket, that little filter. So the little filters can cause distal dissection, so there's something to think about. The edge of the stent there can be a dissection here, especially if there's been an angioplasty. So as you're insenating these devices, you're looking for those kind of problems. And here is an ultrasound of the carotid stent. A very normal laminar flow now, fairly low velocities. Basically a fairly normal ultrasound study afterwards. So TCAR is the new option for stroke prevention. The stroke rates for most of the carotid surgery is less than 1% in experienced hands. There's a saying that if you're over a 3% stroke rate as a surgeon, you shouldn't be doing the operation, because statistically you're not helping people. And so you really have to have a high level of success to be an operator for carotid surgery. So TCAR came along to try to reduce some of the stress in that part of it. It's transcarotid artery revascularization, and it combines a couple things. It combines the direct carotid access with a strict high-grade flow reversal during the placement of that stent. And so what happens is, if this is the carotid lesion, you have a little catheter that sits right here. There's a connector that connects that catheter to the venous system. So now you have blood pressure 120, pressure down here of 10. You're going to have normal flow towards the venous system. And so that's basically your reversal of flow from the brain through the lesion back to the system here. And then you can place a stent and blow it up and do what you need to do. And that actually then repairs the artery. They have a very low stroke rate with that, 1.4% in the clinical trials. And this is where we get control of the artery. We put the little sheath in. And then this is the basket that we see all the debris. So this is all the stuff that happens when you put the stent in and you aggressively expand the artery. that those little pieces break off, and these are all little strokes if you didn't have this system to kind of clean that out. And so in summary, the transcarotid artery revascularization, or TCAR, is a safe, effective treatment for patients with extracranial carotid disease. The outcomes of the trial showed excellent for low-risk problems for symptomatic disease. Outcomes of TCAR consistent across physicians' hands. And so if you have basic experience, you can still deploy this with a high degree of safety for your patients. And so where does that place the vascular lab? You know, I think when we're looking at lesions like this and talking about carotid disease, if we're doing an eversion endarterectomy, you need to know that. If you're doing a patch, you need to know what the operating report says. If there's TCAR, you got to be worried about the access site, which is down here. So you're basically doing your general survey as you normally would your arterial system. The criteria is still basically about the same. You're still doing the same criteria that we have used, historically. And there's been many different labs use different criteria depending on which kind of camp you're in, whether you're Strandis or what have you. But IAC is trying to get a consensus together and standardize this process so that we are reporting more evenly across the literature. And so, over 70, we want greater than 230 systolic, we want over 100 diastolic, ratio of 4, and our lab's fairly consistent with that. I think most labs should start to move towards that direction to get some interoperable connections between, communications about what carotid disease is and how to interpret the level of disease for these patients. So there's really not too much that changes. I would say that it's important to know the operation so you can look for potential different complications, knowing the different types of things that we do, and just keep doing your standard excellent work, and we'll figure these out and take care of these patients. So thank you. So we are running relatively on time. Is there any questions to the panel for over the last 3 talks? I'd be curious. Okay, so we do have a question.
Question for Sarah. When documenting reflux in the gonadal veins, talk about Valsalva. I have a hard time doing abdominal Valsalva while maintaining the vein at the same time and not falling off. So for me, sometimes I really think it's there, but have a hard time documenting that. Are there any tips, tricks you might have to elicit that venous reflux there?
Yeah, I don't Valsalva a patient when looking for reflux within the gonadal vein for the same reasons. Everything shifts down and it's hard to stay on the vessel. So instead, we would put the patient either in reverse Trendelenburg or stand them. If you have a bed that has a footrest on it, try it because it makes a world of difference. Valsalva is, in my opinion, not the way to go.
Hey, a question for Sarah on basically when you were talking about positional compression versus fixed compression, like what validates intervention? Is it based off of symptoms? And what's considered like technically compression if it's only if the vessel is compressed in one position and not in a standard like rest position?
Yeah, I think that's a really good question. I think that's where we're kind of heading. We're kind of opening this little peephole of like what is truly compression, and that's where we can come in play a role as sonographers to identify whether or not the compression, when I say fixed, is going to maintain that same velocity criteria in multiple positions. Instead of just supine. Like, we're so used to just saying, okay, it's supine, now they have compression, but is that truly compressed? And yes, largely it's going to be based off of patient symptoms. We shouldn't be treating anybody, and Dr. Lissar, maybe you can chime in here, that is asymptomatic for the same reason, like carotid disease. We're not going to go in and start doing a CEA on everybody, right? You're treating patients' symptoms. So even if you see it, you don't have to treat them just based off of imaging alone.
Yeah, and I would just echo that. It's the symptoms, and it needs to be severe. It's not like, yeah, I have a little swelling and I get a little leg pain. This is, the kind of swelling is, I come home from work and I put my legs up against the wall so they drain for the next 4 hours so I can go to sleep. That kind of swelling. Or the pain is like a broken arm kind of pain. And if you find those patients and you find compression, they generally, you can fix them. But it's those patients that are in the middle where you're trying to decide, is this something real? And on IVUS, it appears that they have obstruction, and they still don't get better. And so, there are other pathologies that it can be. I mean, you've gone through a list of different things that can cause pelvic pain, and so, with venous reflux as the second cause of pelvic pain, there's a whole list of causes. So. You can have some compression, and maybe that's not the pain they have. And so some patients have two problems. I can fix one, but they still have an additional problem. The question is, did we miss it? Are we missing something here? Because this is still too new. This is only 3 to 4 years where we have the technology to actually fix this. So we're still learning, and your center is really pushing the envelope to figure out, who shouldn't we fix? And so I think she's onto something. Any other questions?
I have a question for Sarah. Do you have an algorithm that y'all follow where you do the bilateral reflex and an IVC, iliac vein? Which patients do you choose to duplex the iliac veins?
We don't make that decision. It comes from the provider. So the patients come into our clinic first for a consultation, and then based off of their symptoms, they're either going to have a lower extremity study to evaluate for reflux. And that doesn't always mean a deep and a superficial evaluation. It can maybe only be a superficial varicose vein mapping. But if they have pelvic symptoms, they're going to get an IVC to evaluate for pelvic reflux. So it just depends on the provider.
Dr. Lissar, I have a question about when you're following up your TCAR patients and scanning them, what your experience has been with their patency. I know since we've been doing TCAR probably for the last couple of years, we scan them 3 times in the first year and then yearly after that. We have yet to see any in-stent stenosis. I just wondered what your experience was here, and also potentially, do you think maybe it's the differences in technique between the transfemoral and the TCAR? Can we be more aggressive, or are we probably more aggressive with ballooning and angioplasty in TCAR? Maybe do you see a difference?
Yeah, I think you're onto that, and you may actually have better data than I do. I do mostly transfemoral stenting. My younger partners have done the TCAR training and like to do some of that work. You can be more aggressive, and you can really open up that vessel appropriately, get laminar flow. Whereas when I do transfemoral, I'm doing minimal stenting because of the embolization risk. So everybody saw this little filter with all that stuff in it. That's the last thing I want to get loose and go to the brain. So, I think you're probably correct. It's probably more technically aggressive, the TCAR approach. I don't have the data to kind of say that, but I think it's interesting insight. All right, we're going to move on to the next session. Thank you.